Wonderful. I think we've got a few others joining, but we're kind of at a slower pace. So we'll get started because we have a really packed morning for you. Very warm welcome. My name's Alisha Davies. I'm the Public Health AI lead at the Alan Turing Institute. I'm also the head of research and evaluation in Public Health Wales. But I'm here really with two colleagues, Elliott and Sam, as co-chairs of the new Faculty of Public Health AI and Digital Health Special Interest Group. And we're absolutely delighted to have this event today, a virtual event, so people can join us from far and wide as part of the AI UK Fringe series, actually, that's running. AI UK was earlier in this week, and there are a number of fringe events spanning AI across lots of different disciplines, but health being front and centre in that space. So today's meeting, we have a couple of hours with a packed agenda covering kind of the future of public health, an introduction to AI, some of the applications of AI across different domains, and of course an important focus on ethics and equity at the end as well too. We have a a Q&A section. So we want your input and your questions throughout the morning. So do pop your questions in there. Shortly in a minute, we'll pop the agenda in the chat as well too for you. So you have that to hand. You can see the plan for the morning. We also have factored in a little tea break, if you like, or a comfort break in the morning as well too for you. To make you all aware, we're recording the event. There's some that can't join us today, and if you want to catch up at another time, and then we'll be promoting it on YouTube later on. So we'll share the link with that as well too. So without much further ado, I would really like to give a really warm welcome to Kevin Fenton's joining us as the President of the Faculty of Public Health. So Kevin, if you would like to come in.
Thank you very much, Alisha.
Over to you, Kevin.
Wonderful. Thank you, Alisha. And hello, colleagues. I'm Professor Kevin Fenton. I am the President of the UK Faculty of Public Health. And thank you, Alisha, for inviting me to say a few words, and for your and our colleagues working on the AI and Digital Health SIG, the Special Interest Group's leadership in this space. Now, this event is a fantastic opportunity to come together to consider the opportunities and challenges in developing our use of new and emerging technologies in public health. One of the key areas of focus for the Faculty of Public Health is the future of public health and how technologies such as AI and digital health may shape our future practice. And I'm really grateful for the leadership provided by our AI and our digital special interest group in this space. Now, the reality is that we face a complex landscape in public health, big problems requiring big solutions. We absolutely must build on the experiences of the COVID-19 pandemic and take forward learning and legacies as we build our future health. And artificial intelligence certainly holds promise to help with many of the challenges we faced with and during the pandemic, but also as we've emerged from the acute phase of the pandemic into the cost of living crisis and multiple concurrent threats. In health protection, AI can assist us in analyzing patterns of data for almost real-time surveillance and disease detection. In health promotion, AI can offer targeted and personalized health advice based on personal risk profiles and behavioral patterns. And in supporting our health services, the power of AI can help to detect abnormalities in screening tests, such as mammography and cervical cytology. However, we also need to consider the risks of AI and ensure that our practice remains grounded in the principles of equity and justice. Dame Margaret Whitehead's recent review of equity in medical devices demonstrated the work we still have to do in ensuring that new technologies do not perpetuate unfair biases and risk widening health inequalities. It is critical that we're having these conversations to both limit the risks and to maximize the benefits and opportunities for the use of AI in public health and in wider society. So, colleagues, I welcome this event and look forward to the contributions of the excellent speakers that will be joining us today. I hope this is the first of many conversations that we'll be having as a faculty with our partners on the future of public health, the role of AI and technology, and how we can leverage these new technologies to improve population health and tackle inequalities. Thanks, Alisha. Back to you.
Many thanks, Kevin. Many thanks for such a lovely welcome and opening in such an important area. And it's fantastic to have you here joining us today. Someone's just popped into the question about a link to the reference that you made there to Margaret Whitehead's work, Kevin. So I'm sure we can address that. So we'll pick that one up and pop a link in whenever in a moment. So that's kind of the framing. I think what's really important is also to reflect on or to try and start that kind of common understanding about what AI is and what AI is not. And I'm absolutely delighted that joining us this morning is Florian Osman from the Alan Turing Institute to give us a bit of a rattle through what is AI. So Florian, I'm hoping you have all the answers for us.
Thank you very much, Alisha, and good morning, everyone. It's a real pleasure to be here today. And yeah, I have the honor to try to contribute to setting the scene by addressing this question of what is AI. Now, as I'll explain in more detail in a moment, defining AI actually isn't an easy task. And of course, going into technical detail on sort of the underpinnings of AI systems would take a fairly large amount of time. I've only got 15 minutes, so I've decided to keep it relatively lighthearted. But hopefully, sort of what I'll set out will help frame the discussions for the rest of the day. And I also hope they won't offend those of you who have sort of deeper knowledge of AI already. So yeah, bear with me as I try to give sort of a high level, maybe hopefully slightly entertaining in some instances overview of what we mean by AI. Now, to start with, we might think of a definition of AI. What is a useful definition? What's the scope of the kinds of technologies that fall under the umbrella of what we would refer to as AI? Now, as those of you who've been following the debate for a while may be aware, that's really not an easy task. So, anyone who's been working on AI regulation, for example, in recent years, will be aware that there's been quite a controversy around setting up a definition for AI that defines the boundary in a way that's neither over-exclusive or under-exclusive in terms of what kinds of technologies will fall within the regulatory remit, for example, sort of making sure that a simple Excel spreadsheet doesn't all of a sudden count as AI, but also making sure that the definition isn't too narrow. But let's take a step back and think about this historically. If we do that, I think a useful starting point is a definition that's often quoted, the definition on the slide from Marvin Minsky, one of the founding figures in AI as a research field. It's a definition from 1968, according to which AI is the science of making machines do the things that would require intelligence if those things were done by humans. Now, the reason I chose this definition as a starting point here isn't necessarily that it's a particularly helpful definition. We'll get to that in a moment. Part of the reason for choosing this was the date, actually, and sort of to emphasize that AI as a field has existed for quite a long time. So, as a research field, it's existed since the late 50s. And so there's a long history of research and technology development that predates sort of the wave of interest in AI that we've seen over the last a few years or the last decade. I think that's an important point to acknowledge at the outset. But let's think about some examples, concrete technologies that we may come to mind when we think of AI. And if you think about those early days in 1968, one thing that may come to mind might be a chess computer. Trying to develop a machine that can compete with humans in playing chess, right? You may also think of route planning applications, for example, right? Using a computer or a smartphone to help you get from A to B in a particularly efficient way. Some of you may think of optical character recognition and may remember sort of the breakthrough in the 90s when it was possible to use a scanner to scan an image of a page that contained printed text and to be able to transform that into a document that recognized the letters in that text. Some of you may think of speech recognition, the ability to dictate something to a computer that's being transformed into text, say in word processing, for example. And then maybe some of you might think of this little toy, by which I'm not referring to the dog, but to the vacuum cleaner on this image, as a tool that may be considered intelligent to some extent. So those are some examples, but some of you may look at all of these and say, hold on a minute, all of these things have been around for a really long time. They're so omnipresent. I use Google Maps every day. I use speech recognition every day. None of that seems particularly intelligent. My vacuum cleaner hits the wall all the time. So is any of that really artificial intelligence? That's sort of highlighting, I think, one important aspect of the field as it has evolved, which is the fact that once technologies are developed and become commonplace, they're often no longer thought of as AI. So something's thought of as AI while it's still out of reach or when it's within grasp, and when it's widely adopted, it just becomes commonplace and not necessarily thought of as AI anymore. But I'll add some more contemporary or more recent examples to show that in each of these areas there has been progress, and there's always sort of the edge of innovation where there are examples that clearly people would think of AI. So in game playing, for example, chess, of course, is a relatively simple game compared to other games. Go is a much more complex game, and many of you may be familiar with the breakthrough of Google DeepMind developing a system that could beat the human world champion at that game. You might think of targeting, in social media context, targeted advertising, how efficient and effective that has become, as a more recent example. Is sort of in the image processing space, facial recognition or image recognition. In the processing of human language, think of assistants like Alexa. And then on the robotic side, the more advanced examples, you might think of self-driving cars or other forms of robots that may assist humans. Now, I think there are two lessons here from looking at that big picture. One is this trend that I mentioned of technologies, once they become widely adopted, not necessarily being thought of as AI anymore. And then the other point is sort of the wide range of different types of technologies that fall under the umbrella of AI. And I think the grouping of the images captures sort of four big areas. The first one on the left sort of relates to tasks of data analysis, modeling, prediction, optimization. Then in the middle at the top, image processing related tasks. At the bottom, tasks that relate to the processing of human language or natural language, as it's often referred to. And then on the right side, robotics and applications of AI in the robotics context. And I thought I'd briefly highlight that, for each of those four areas, there are significant applications in the health context and applications that may be of interest from a public health perspective. So on the data analytics side, for example, an example might be pandemic modeling or disease modeling in general. Think of the COVID-19 pandemic and how innovative ways of modeling social interactions may have helped in predicting the spread of the virus. Resource allocation decisions, for example, in hospitals, or emergency service management as an optimization task. On the image recognition side, Kevin already mentioned cancer detection as a very prominent application. When it comes to language processing, human language interactions, chatbots, for example, in the mental health context, or symptom checker apps. And then on the robotics side, you've got sort of care robots that are quite widely advanced in terms of development, especially in Asia, or other robots that may help with different medical tasks. So I think that's hopefully sort of a useful overview of sort of the breadth of things that fall under the umbrella of AI and their sort of applications in the health context. But you may still look at all of this and say, none of this really resonates with what I'm thinking of when I hear AI, and especially if you've been following sort of the media discourse over the last few months, over the last year. You might say the kind of thing that I think of when I think of AI is this. So some of you may be familiar with this. These are, of course, two deepfake images that are generated by an AI system, by what is called generative AI, in this case, generative AI systems that create images. And a very prominent example of sort of the more serious uses of generative AI, of course, is ChatGPT and other tools developed by other companies like Bard by Google, and so on and so forth. Now, I mentioned this for two reasons. Firstly, to say that there has been a shift in discourse quite significantly over the last year, let's say. I think for people to think of AI as primarily these things, generative AI systems, and I think it's really important to bear in mind that AI is a much wider field, including all the areas of application that Kevin mentioned in the introduction that sort of predate generative AI. But then also to say that, of course, there are questions in the generative AI context that, again, touch on public health. So you might think of when it comes to deep fakes or misinformation in general, again, think of COVID-19, for example, the risk of misinformation and more generally, AI-generated misinformation that may impact public health. And of course, there's big questions of how a tool like ChatGPT could be used responsibly in a public health context. So that's a sort of that's the more light-hearted part of trying to provide an overview. But on a bit more serious note, if you move on, trying to approach this question of what is AI in a more analytical fashion, I thought this kind of schematic might be a helpful way of framing the discussions for today. So as the examples that I've shared show, there are areas where AI is applied in connection to robotics. So we've seen the care robots, for example, and then that's often referred to as the area of intelligent robotics. But what's important to bear in mind here is that the intelligent part, of course, is the software. The robotics, the hardware part, wouldn't generally be considered, AI. So when you think of AI, we generally think of software-based systems that may or may not be connected to physical systems. Now, when it comes to those software-based systems, historically, if you think back, again, all the way to the 50s, there are two broad paradigms for developing AI. The first one is an approach that relies on explicitly programmed rules. So that's often referred to as rules-based systems, sometimes referred to as expert systems. That was a dominant approach sort of in the early phases for the first few decades in the AI research field. But what we see as sort of underpinning the huge leaps forward in AI. That's been driven in the last few years, the last couple of decades, that's been driven by a second paradigm, and that's the paradigm of data-driven AI systems. In other words, systems that are developed using a set of methods broadly referred to as machine learning, whereby the development process of the AI system relies on developing a system that is being trained on data and learns from exposure to data how to perform a certain task, as opposed to being explicitly programmed how to perform a certain task. So machine learning really is at the core of what we see in recent advances of AI, and as at the core at all of the examples that Kevin mentioned earlier as well. In addition to machine learning as a methodological framework, there are two other aspects that often drive the kinds of innovation that we see that are referred to as AI. The second one is the use of non-traditional data. So a lot of progress has been enabled by not just using machine learning and using ever more sophisticated machine learning methods, but also having access to forms of data that hadn't been exploited traditionally. So if you think back, for example, to pandemic modeling, you may think of the use of social media data, for example, to help with the analysis of patterns of social movement, for example, or other forms of non-traditional data. And then the third element is the element of automation, which involves removing human decision makers or reducing the role of humans in decision-making processes, which can, of course, have all kinds of benefits in terms of efficiency or removing human error. So that's sort of a schematic representation of what I think is useful to bear in mind in terms of the three elements of innovation, as you might say, that underpin AI innovation. When it comes to those systems, broadly speaking, systems that rely on machine learning, I think it's helpful to briefly touch on the processes that underpin their development and their deployment. And I'll keep this quite brief. I'm sure that this will be touched on later on, and I know that Chris will be ending the session today with a presentation on assurance and ethics, where I'm sure some of these themes will come up as well. This slide, what it's trying to do is sort of to capture a sort of standardized view of the life cycle of developing and deploying a system, which includes the inception phase, where you think about the design of a system. Then, crucially, the data preparation phase, which is really important to highlight, because a lot of important decisions that impact the performance of a system, also that are relevant from an ethical perspective, fall within that data preparation phase. And of course, the phase of designing, developing the model, verifying, validating it. And then there's the deployment phase. It's really important to emphasize that there's ongoing monitoring, or there should be ongoing monitoring of performance after the deployment. There's a need to reevaluate how systems perform over time, especially for those systems that are updated continuously. So that's not the case for all AI systems, but an important subset of AI systems that are exposed to data in sort of a live fashion and update their parameters. And that, of course, may lead to improvements of performance, but it could also negatively impact the performance. It's really important to monitor those things. I'll end with a short slide, again, without going into detail on challenges and risks. I think no introduction to AI would be complete with mentioning that in parallel to, alongside the significant beneficial impacts and the benefits of AI, there are challenges in terms of using AI responsibly, and those challenges need to be taken seriously and need to be addressed. Those challenges arise from in various ways from the different characteristics of AI systems, the fact that they will often be adaptive, that they act with different degrees of autonomy. They may be very hard to interpret in terms of how they function due to their opacity. They are, if they're based on machine learning, ultimately statistics-based systems, so they're non-deterministic. They're trained on data, so they will reflect the quality of the data they're trained on. And they can, of course, be very energy consuming. So the concerns range from social concerns all the way to environmental concerns. And that can translate in various ways if those things aren't managed properly to harms to people, to organizations, and also to wider society. The good news is that over the last few years, we've seen emergence of a really, really rich literature and a set of practices to manage those issues. Those are often broadly referred to as AI assurance practices. This slide sort of gives an overview of some examples of those practices for AI assurance that can be adopted by the organizations that are developing and using systems, but also practices of assurance that involve external parties, such as third-party auditors or certification schemes. And so we've seen, a maturing system of frameworks for addressing these issues and ensuring that AI is used responsibly. But again, these are all things that I'm sure will be covered in more detail by Chris later. And so I'll stop here and yeah, happy to answer a couple of questions if we have time.
Many thanks, Florian. That's fantastic. A really lovely introduction and transfer over into different domains of public health as well too. And we'll come into a bit more on that. There was a couple of questions in there for you, but they're both kind of reflective of human in the loop. So how do we assure that there's that kind of innovation in AI, but ensuring that there's the human context in there? So the two questions, the one about chatbots for mental health and that kind of lack of a human interaction, and the other is the human oversight where AI is used in automation in terms of efficiency generations. So if you can give a reflection of your thoughts on that kind of human in the loop element.
Yeah, thank you. I think they're both really important questions, and the wider theme of human involvement is absolutely key to questions of responsible use. On the human oversight question, I think what part of the reason why I try to separate out the machine learning component from the automation component is that in debates they often tend to be conflated. So we often assume, in sort of public discourse that AI systems are by default, automated systems. And that's not necessarily the case, right? So we can have systems that leverage the benefits of machine learning, but don't lead to automated decisions. It's a step to design a system to make the decision to remove the human decision maker, right? You can just as well have a system that makes a recommendation that a human decision maker looks at and then, decides autonomously whether to act based on that recommendation or not. And I think especially in the medical context, we've seen quite wide acknowledgement that, for example, for medical practitioners, it's really important to maintain that element of autonomy and human decision point. It's also, of course, not black and white. So if you remove the human decision maker from making an active decision, you can, of course, still have all kinds of forms of human oversight and risk management. So there are various ways to think about the role of the human, but it is a really important question. And on the chatbot side, I think it raises two important. I'll just say I think there are two important aspects. There's the aspect of things going wrong if there's no human there, right? But then also, especially if you take an example like the mental health chatbot, the value, the subjective value of actually interacting with a human rather than interacting with a machine. Because it's not limited to mental health. You might get the same in physical healthcare settings, where we need to think about what is the value of setting aside sort of the accuracy of decisions or of the way in which patients are treated. What is the intrinsic value of interacting with a human rather than interacting with a machine?
Think many thanks, Florian. I know you need to head off. There's a couple of other questions, but maybe we can send them off to you and you can have a think about them. A huge thank you. It's really, really helped us to set the scene this morning. We're never going to, as Florian said, cover the whole of AI in 15 minutes. But as I said at the start, this is the start of this AI and digital health special interest group. So there will be more to come, I hope, in the future. So a huge thank you to Florian. Someone had asked, are we recording and are the slides available? We are recording. And it will be up live at some point, and we're more than happy to send that link round to you all whenever that's ready. So now I'm handing over to Elliott for the second part where we think more about some applications. Thanks, Elliott.
Thank you, Alisha, and thank you again, Florian. I think that's an excellent foundation for us to now consider the application and implications of AI on public health. In this part of the webinar, we're asking, does AI present a new horizon for public health? And we're scanning across different areas of public health practice to see what that horizon might look like. We have three fantastic speakers who are currently using AI and will give us a flavor of how AI is shaping three different domains of public health. Dr. Anya Skotova is a UK Research Innovation Future Leaders Fellow in Population Health Sciences at University of Bristol and will focus on prevention. Professor Sian Taylor-Phillips is a Professor of Population Health and Director of Warwick Screening at Warwick Medical School and will focus on screening. And Professor Marta Blanchiado is Professor of Biostatistics at Imperial College and will focus on surveillance using wastewater. Our speakers have 15 minutes to present, and then we'll have 15 minutes for a Q&A at the end. So please do enter your questions in the Q&A box or upvote other people's questions. Just a reminder that this part of the session and the Q&A will focus on the current and future applications of AI to public health. And then following this, we'll have a session and another Q&A on the challenges of AI, particularly around ethics and equity. So Anya, if you are ready, over to you.
Yeah, thank you. Just let me share my screen. Can you see my full screen? Yeah, hopefully, yes.
Yes, we can.
Yeah, great. So just try to get rid of some of the, yeah. So thank you so much for inviting me. Really pleasure to be here and present my work. So I'm Anya Skotova. I am based at the University of Bristol at Bristol Medical School, Population Health Sciences. And I'm also fellow at Alan Turing Institute, and I lead Digital Footprints Lab. So I will talk about digital health and promotion and what kind of insights we can gain and opportunities we can gain from digital footprints data. Novel digital footprints data is all around us. And by digital footprints data, we mean digital recordings of our behaviors that kind of happen while we interact with various services. So loyalty cards and shopping data recorded through loyalty cards, something I'm going to be talking a bit about today because that's the focus of my work. But digital footprints data also includes, records of behaviors, for example, through services like social media or wearable devices, banking cards data, and so on. This is really interesting data for me as a behavioral scientist, which is my background before I became health data scientist. Because it gives us a really interesting insight into people's behavior that we kind of didn't have before. And I will kind of try to unpack how it's relevant to prevention, promotion, and public health in general. So novel digital footprints data. We kind of, with these data sets, we go from thousands or maybe 100,000 of participants that we can access through the best longitudinal population studies to millions of individuals with billions of transactions or entries. We can tap into real world behavior, so behavior not self-reported or lab-based measures of behavior, but actually people's actual choices in real world. It's very dynamic measure of people's behavior. It's time series, so it's multiple measures per person. It's sometimes close to continuous time scale. So for example, if you take wearables, it is continuous. If you take even shopping data, it's a lot more kind of a lot more continuous than, let's say, a food frequency questionnaire that you can might otherwise use. It is also very granular, so very detailed, and it can go back in time as long as the records allow. The scale is again huge. Of course, no sample is representative, but because we have the representation of the whole population, for example, in national supermarkets, we can actually get to close to representative samples. And impact, we think the impact of using this data for public health is enormous, and it can change the way evidence for effectiveness of policies is collected. And some other, I will make some other suggestions as well later on. So how digital footprints data can be used for health research and especially for promotion and prevention of public health. So I think an important setting information here is that while there is a lot of gold standard measures of public health and also a lot of novel data that has been used, like health records, there's still important health information missing about population. This is due to various reasons. So, for example, some issues like mental health are poorly reported due to social stigma. Other behaviors which are like for example, the length of exclusive breastfeeding on lifelong health, notoriously overemphasized in public health domain, but we actually don't really know the extent to which women breastfeed because it's very contentious issue. There's loads of pressure to breastfeed. So women perhaps not often reported accurately. Of course, there is in the domain of diet, there's loads of biases in reporting because people self-present, also forget. You know, if you think about how many snacks you eaten yesterday, you know, you're not always going to remember exactly, you know, everything in the way that nutritionists would want you to report. And this is all the information that a lot of public interventions are based. And in the domain of adherence to medication and generally in a kind of over-the-counter medication domain, we kind of know when people go to the doctor and report their symptoms. We also know when the medication is prescribed, but actually don't know whether people take it. And all this information can be contained in shopping data. So this is just like a brief overview how shopping data can be used for research. The interesting feature of it, their events happen over time with the same people and we can track them. Not only we can track them as researchers, but also supermarkets notoriously have tracked them over years. So for example, somebody might be buying menstrual products every 28 days so that we know they menstruate, then they stop buying menstrual products, buy pregnancy test, and then 9 months later they start buying baby products. So we know what happened, or at least can assume, to this individual. And then in this each time point, we can study various associated things that happen to them. So for example, we can look whether they were purchasing painkillers together with menstrual products and kind of assume or reasonably assume that they might have had period pain or suffer from period pain. We could look into their diet at the time when we think they were pregnant and look how it affects the future outcomes. And we can look at, for example, products that they start buying alongside baby products, for example, remedies for related kind of indicating that they might have mental health issues. In our lab and kind of people who we work with across UK, we have a range of projects using digital footprints data, specifically shopping data. So as I said, we looked at various issues to do with reproductive health, but also colleagues done some work to do with respiratory illness in COVID. There's a lot of interest in obviously diet, for example, looking at ultra-processed foods and how they might be linked to cancer risk factors. We have projects on chronic pain, alcohol consumption, and so on. So there's loads of interesting public health domains that could be investigated using this data. We also not overlook public acceptability and ethic issues, and this is kind of a big part of our research program, and data linkage, which I will come a little bit later on too. So what are the barriers for health research with digital footprints data? Well, there's still a lot. Obviously, this data hasn't been collected for research. So we need to do a lot of work before it's usable, which we're doing now. It's not a trivial task. There is issues with quality of the data. We not always know. I made you examples of how we can assume certain things happened with a person, but of course we can't know it. So there's loads of validation exercises that we need still to do. There are obviously sampling biases in the data, although they are of a different nature to biases in other data sets. So it's important to understand them and triangulate. Traditional statistic methods are not always applicable. So the data is very sort of multidimensional in the way that traditionally in health and social science, in medical research, we haven't been used to. So increasingly, we are using machine learning and AI methods. But it's really important to not just use machine learning methods because they can, deal with this amount of data, but also understand what's happening there, because we want to understand what's happening to the people, not just predict certain behaviors from features that, can't be explained. So I think the explainability of using machine learning methods here is really important. The data is sparse. When you, for example, go to supermarket, you don't buy everything, you only buy certain products. So there is loads of missing data. And there is kind of in the way very different to survey or experimental data. The missingness also happens at different time points, because some people go to supermarket, let's say, every day. Others would go once a week, and other people would even less frequently. People exercise at different rates and so on. So kind of aligning all these data sets to make useful conclusions is challenging. And of course, there are ethical and acceptability issues that we're also looking into. So one of the major programs that I'm leading now, and approach to kind of one of the approaches or frameworks to deal with those challenges within digital footprints data, is linking this data into longitudinal population studies. Those are cohorts of people that have been followed over years, often decades, and the UK is very famous for its established studies. One of them, example of these studies, is Avon longitudinal study of parents and children, which is hosted in Bristol, and I work with most currently, otherwise known as Children of the 90s. You might have heard about it. This is a biomedical, initially and primarily cohort that has been followed for 30 years. So the index generation has been born in 1991. And they have been followed extensively. The genome is sequenced. They been multiple biomedical measures across life and social measures. So now what we're doing, we're linking shopping data after a lot of acceptability work. We're linking shopping data into that database. So we actually already linked it, I should say. That is allowing us to do a lot of proof of concept linkage and data management and methodological research to understand basically what shopping data shopping data sets allow to tell us and what they can't tell us. To deal with issues like sampling biases and measurement error and validation issues. And the next step is a program of research that I'm leading with others in UCL and Edinburgh, is to link this data across multiple studies. and not just shopping data, but other types of digital footprints data. So we can then do a lot of important research for contributing to population health. So what are opportunities for health prevention promotion with digital footprints data? And this is just some examples that I made, but there are many more. So as I mentioned before, we can evaluate policy interventions. So for example, we can look at interventions like minimal alcohol, introduction of minimal alcohol unit price, and whether it actually makes a difference to people's drinking habits. It can provide evidence base for new interventions. So, for example, if we study, if we understand better how we can study chronic pain through shopping data, we can then assess different parts of the country for, you know, the amount of painkillers people buy, and perhaps suggest that certain parts of the country should introduce pain clinics in specific areas. We can, there's a potential to detect invisible health symptoms. So when I say invisible, is invisible for kind of medical system. So kind of look into areas where people self-medicate before they go to the doctor. And there has been a study that made rounds on the news on early ovarian cancer diagnosis. So the researchers from Imperial were able to show that shopping data is associated, certain patterns in shopping purchases associated with cancer diagnosis for before people even been diagnosed. So the symptoms were kind of showing themselves up, and people were sort of self-medicating, and then you know, that can be detected through shopping data. We can also provide more accurate information of lifestyle choices such as diet and physical activity.
And yeah, we're at 15 minutes. If you could begin to wrap up, please.
Yeah, I almost finished. Yeah. And we can create opportunities for self-reflection through self-realization. So we know that just knowing what you eat and how much you exercise actually helps people to regulate it. So there's good opportunities there too. So just to wrap up, I represent community of researchers, and a little plug, we're going to have a conference in Bristol on the 9th and 8th of May. And on the 8th of May, I will run a workshop, which is focusing on digital footprints in longitudinal studies. And on the 9th, we have a really great conference with loads of people coming from across UK, 5 really interesting interdisciplinary workshops, and so on. And just to flag that some of this work, this is my team, by the way, and some of this work is also supported through our special interest group at Alan Turing Institute, which you can join if you wish to. You can find us on Turing website. Thank you very much.
Thank you, Anya. I find it really quite exciting to think of the possibilities of using AI to understand behavior using digital footprints. I can imagine there's some people that would be quite nervous about that. It seems an area where getting the public on board and building that acceptability will be really key. I'm going to move swiftly on to Sian if you're ready to present. Anya's not able to stay for the Q&A, but happy to be contacted directly if you've got any burning questions. Do please put them in the chat. Sian, over to you.
Thank you. Let me just share my screen. Can you see my screen?
We cannot, not yet.
Okay, interesting. Let me try again. Share.
Yep, that looks great. It's starting to come. Perfect.
Okay, fantastic. So I'm going to talk about the use of AI focusing on screening. So my work mainly is synthesizing evidence for policymakers, and my team in Warwick Screening, that's what we do mainly. I also serve on the UK National Screening Committee, so we advise the 4 UK governments on screening policy. and I chair their research and methodology group, which gives advice to researchers about how to make research more useful to the National Screening Committee. And I need to say that I'm going to tell you all about my own views and not any of those organisations. So I'm going to start first by broadening out from AI. So thinking about what I think is the public health approach to screening, and then what this means for AI, and then zone in on breast cancer screening as a specific example, which is one of the most popular examples. So what I think of as the public health approach to screening is we think about people's outcomes. We want to do more good than harm at reasonable cost. And this is Mike Richards' review of current adult screening programmes in England, screening 12 million people, costing over £600 million, preventing over 10,000 premature deaths, but also harming over 160,000 people with anxiety from false positive test results, i.e. the screening test says it's positive and actually it's negative, which gives people anxiety, and giving over 8,000 people unnecessary treatment because you're overdiagnosing disease that actually didn't need any treatment. So screening is a really complex picture. And I love this paper. It's from back in 2015 by Fiona Miller, but it really explains some of the conversations that you have. And so she conceptualized, this was for the newborn blood spot screening test, but it kind of applies more broadly. She conceptualized 3 communities of practice. Public health people are focusing on the evidence that it does more good than harm for the population. And then clinicians, which is here as primary, maternal and child health, but people who really care about their patients, their day-to-day is seeing patients, they care about care delivery, and they want better outcomes for those patients. But they aren't really exposed to asymptomatic people. So there's a whole kind of natural history of disease that they're not aware of. And then at the bottom, she talks about geneticists, but it actually is broader to sort of a range of technical test advocates who are really focused on the test and can we detect more stuff. So she mapped out what she thought in different countries was the level of kind of authority and involvement in decisions of these different communities, and basically said, when you have more public health involvement, you tend to be more cautious about implementing screening. And in countries where you have more public health involvement, you might screen for, say, 10 or 20 conditions in the newborn blood spot test. Ones where you really know that treatment works and earlier treatment after screening is better than late treatment. Whereas countries where there's more sort of test advocate, geneticist-led, you tend to get more like 50 to 100 conditions because that's what the test can detect. And then the final bit on the public health approach is an example. So if we think about neuroblastoma screening, neuroblastoma is a horrible condition, childhood cancer of the nerve. For symptomatically detected people, the 5-year survival, and this is, under 5-year-olds usually, so young children, 5-year survival is 50% symptomatic detected, and it's 97% for screen detected. And actually, the screen and symptomatic detected children appear the same, like they don't have symptoms, the screen detected, but on the test results, they appear the same, that they're indistinguishable. And so there was a period of time where people thought, this is going to be a great screening program. And actually, some people held out and said, let's do big controlled studies. There were two massive controlled studies, and they showed that screening has no benefit at all. It's pure overdiagnosis harm. And what's happening is screening is detecting this new spectrum of disease of neuroblastoma that we didn't know about before, that is self-resolving in children. We don't need to treat. And actually, if you do treat them. They can be very harmed by the treatment. And so we end up with these conversations between people taking a public health approach, which is much more cautious and wants to wait for these big controlled studies to really know outcomes, and people coming from other perspectives who think, gosh, you're taking too long, and why are we waiting? And I can detect this now. So that's the context in which we are developing a lot of new AI tools and proposing them for screening. So I'm going to focus on AI for detection in screening. And you can see some of the current uses. You can use it for lung screening, breast screening, pregnancy screening, diabetic eye screening. There's a lot of other use cases in screening to do with kind of organizing your workflow and prioritization and things like that, which I just won't cover. So let's go through a few kind of cases. So what about AI that can detect other types of disease or condition, incidental findings? So you were looking for a cancer, but you actually found something a completely different disease. So for test advocates and some clinicians, actually, this is really positive. We found more disease. But often people taking a public health approach to screening are not at all enthusiastic about this, because actually now you've got a whole different disease for which you've got to find the evidence to find out, is this beneficial or is this harmful? And so many of the conversations end up being people are disappointed at the lack of excitement of public health professionals for all of these incidental findings. AI can detect more of the disease we're screening for. Fantastic. But hang on a minute. Is it really the same disease that we're screening for? So is it the same spectrum of disease? And we'll come back to this with breast cancer, which is a whole range of different kind of diseases together. Is it detecting a similar spectrum of disease, or is it detecting less aggressive disease or more aggressive disease? Is it more or less beneficial? AI can reduce false positive results. That would be great. So that would be a universal positive, right? But we don't see this. We hardly ever see this. We don't see AI develop to do this. Although for all communities, it would just be a really good thing. If you reduce your false positive results, then you reduce the number of people you're giving incorrect test results to. You remove their worry, and you reduce the NHS resource that has to be used to follow up those people, and that can be reallocated to much more important things. So universally a good thing. We should do more of this. AI can save clinicians time. Fantastic. If AI can do this, that's absolutely brilliant. Again, we want to be freeing up clinicians' time. But actually, how can we demonstrate this? It's really critically important to demonstrate this in prospective research. We see a lot of simulation studies that postulate it's going to save time, but actually, when you put it in the real clinical pathway, it doesn't. And so prospective research is needed. So now I'm going to zone in on the breast cancer screening example. So I led a paper that was our position statement that said, this is what evidence we need for artificial intelligence in breast screening. And we also reviewed the literature about what evidence is out there. So the basic flow of breast screening is a woman comes in and she has a set of mammograms taken. A mammogram is an X-ray. She has 2 X-rays of each breast, and that's sent off, and it's reviewed by 2 experts. They might be radiologists or similar professions. And it takes them a median of about 37 seconds to look at each woman's mammogram. It's an expert task, but experts can do it very quickly. And they recall about 5% of women for further tests. Those further tests take about an hour of clinician time, and about a fifth of those turn out to be cancer. So AI is being applied to save the 37 seconds at this stage. But actually, what really matters for workforce saving is how many women are being recalled. And so we need to show prospectively that you save time. Similarly, breast screening detects a range of different cancers. Low-grade DCIS is mostly overdiagnosis, and we don't really want to detect it. There's trials underway to scale back or remove treatment. Grade 3 breast cancer, very aggressive, significant survival benefits. So if AI views these two things equally, both the true positive, then we'll drift towards more harm, less benefits.
And you've got 2 more minutes.
Great. So the best thing you can do is fit the AI to complement the clinicians. So this is how the human clinicians are currently performing. They're detecting 75% of the cancers. They've got 5% false positive rate. This is what most AIs are doing. They're performing about as well as the humans, but they're using a different threshold. And then this is where all of the kind of headlines about detecting more are coming from. What they're doing is detecting more, but increasing the false positives. More intelligent AI can funnel what humans see and support them, which is a much better implementation. And wouldn't this be wonderful AI? So this would be detecting the same stuff we detect now, but reducing those false positives. I haven't seen any that are doing this as yet. Finally, I haven't planned to talk about inequity. In screening, inequity and inequality is absolutely central to everything, but I've seen Chris is talking on it later. In breast screening, we know we have inequity of uptake by socioeconomic status and ethnicity, and we know that the tests are less accurate in women of Black ethnicity. And so if we train AI mainly in Caucasian populations, that's going to make this worse, and we want to be making it better. So AI has huge potential, but we should keep our focus on delivering more benefits and less harm. And I'm thinking a lot about how the different communities, academia and industry can come together and actually reach a common understanding on how together we increase benefit and reduce harm. Thank you.
Thank you so much, Sean. That was really clear. And I find the appraisal of screening tools is a really helpful paradigm to think about the appraisal of AI in other contexts. I think it really shows how public health thinking about what a tool can and can't do, and therefore how it should and should not be used, is critical, and demonstrates really the value that public health professionals can add to discussions about safely and sensibly implementing AI across disciplines. Marta, if you are ready, I will promptly hand over to you. Thank you.
Thank you, Elliott. I'll try and share. Let's see. First of all, this. Share. Do you see? Why is it not doing anything? Oh. Okay. Do you see everything? I'm hoping.
Yes.
Yes.
Okay,
Yeah.
great. Thank you. Thank you very much for this wonderful session. I'm finding it really, really interesting. And so thank you for making me a part of it. So my presentation is kind of like quite a specific presentation, maybe slightly different from the previous ones, as in there is a, kind of like it's all about a specific case study. And it's about wastewater and health surveillance. And I'm kind of like presenting on behalf of the Turing RSS Health Data Lab, which was put together during the COVID pandemic, sort of supported by the UK HSA, and it was a collaboration between the Turing Institute and the RSS, the Royal Statistical Society. And it was really to try and use statistics, AI, machine learning methods to help UK HSA to tackle specific issues related to the pandemic. So we worked on several different projects. And the ones I am going to focus on today are the last two. So there's two papers related to wastewater. And now wastewater can be used in the context of the COVID pandemic, sort of like to kind of like predict the dynamic of the disease. So first of all, just a quick overview, a few words on wastewater-based epidemiology in case you're not familiar with it. And that is a collection of tools and methods for surveillance and monitoring, specifically for disease outbreaks. And the peculiarity is that it uses biochemical analysis of wastewater samples. So that is the primary measure. And it has been used a lot over the years. It's not new. It wasn't kind of like just came out during the COVID pandemic. It certainly became more sort of like, commonly used, but it was used before. It has two main advantages. One is there is virtually no selection bias, at least in sort of like high-income countries like the UK. It's also quite cheap, particularly compared to other diagnostics, which, for instance, in the COVID sort of like realm means sort of like testing. It has been used from the beginning. So the beginning of kind of like wastewater epidemiology was to track illicit drugs and psychoactive substances, which remains in wastewater for some time, and then pesticide, endocrine disruptors, but also then moving on, kind of like was used for bacteria and so on. There are some successful stories. In particular, has been used for retrospective prediction of outbreaks of, for instance, hepatitis A and norovirus. And also, it's quite interesting to know that for polio in particular, it is part of the WHO guidelines for the monitoring. So now, it works kind of like in this, how it works is depicted in this illustration. So it starts all kind of like with the shedding, going to the toilet, and then sort of like the pathogens go into the sewage system and they are collected across a network of sewage treatment works, which look like this. And this is where the samples are collected. And at this stage is very agnostic, as in obviously, the wastewater is here and can be used for many different pathogens. In this particular example, I'm going to I'm talking about COVID. And so there were samples of the SARS-CoV-2 virus getting collected, basically analyzed into the wastewater samples. And as you can imagine, there is a spatial dimension and a temporal dimension. A spatial dimension because there are several different sewage treatment works across the country. And there is a temporal dimension because the samples are collected, through time. So sort of like the same sewage treatment works is sampled several times. So these two combination of kind of like dimension make this spatiotemporal, and is kind of like quite naturally a good fit for model-based approach, particularly focusing on advanced statistical methods, machine learning, to basically try to get prevalence of the disease, estimation of prevalence of the disease. And this would be kind of like to produce some sort of early warning. And then this can also be linked with other data like community testing, hospitalization, death, in sort of like more a multiplex, which I'm going to say something towards the end, to basically try and predict more accurately the disease dynamic. So the aims that we had with this project was to develop a advanced statistical model, an advanced statistical framework to estimate viral concentration in wastewater at a fine spatiotemporal resolution. So the idea was to cover the whole of England. And then very importantly, we wanted to evaluate if this spatiotemporal prediction was able to actually predict the disease trend, which is ultimately what we are interested in. So we really took advantage of a very nice sewage treatment works network, which was part of the environmental monitoring for health protection sort of like system. And it included more than 300 sites, which are depicted here. And basically, you can see they cover mostly kind of like urban areas. The idea is to try and cover as much population as possible. For about sort of like a bit less than a year, so between June 2021 and March 2022. And so the idea is to use this as a starting point to quantify the relationship between the weekly viral concentration in the wastewater sample at this level of sewage treatment works, and finding predictors. So finding a set of covariates that can explain well the variability that we see in space and time, and then use this to predict the viral concentration weekly for any spatial resolution that we were interested in, with, very importantly, associated uncertainty. So really, you know, kind of like accounting for the fact that this is an estimate, that we have an uncertainty related to that. So we have a very rich output out of this machine learning geostatistical framework. So for each of the areas of interest, you actually get a full distribution for each of the week of this prediction. So in kind of like in collaboration with UKHSA, we produced a wastewater atlas, which gives a different spatial resolution. So this one is LTLA, for instance, lower tier local authority, but there were also other type of resolution available. It will give this the full distribution of all the prediction across time. So for instance, here is showing Leeds, and it will give you basically all how the prediction changes over all the period under study. And obviously here you also get a picture of the entire of the country and how this changes. You know, this is for a particular week. The other thing that UKHSA was interested in was trying to flag trends which were increasing. So the idea is really to try and highlight if a specific area is showing a trend in wastewater viral load, which is getting higher and higher. So that probably means there's going to be kind of like an outbreak there. So we ended up with this map of probability where you get the red. It means that over the past 3 weeks, the trend kept increasing. And again, this is done on a weekly basis. So in a way, kind of like it's possible to dynamically follow what is happening and then sort of like try and zoom in and check specific areas if of interest. Now, unfortunately, I can't really show you the whole atlas online here, but I've put a QR at the end in the last slide. So if you want to have a look, it's fully available online. Now, obviously, after we've done all this work, what we were very interested in was to actually see if the wastewater we predict, has kind of like any meaningful relationship with the prevalence. So just looking at a kind of like a descriptive level, we looked at accordance between wastewater concentration and the COVID D-bias prevalence. And the D-bias prevalence was the output of another of the lab project, which was really to try and tackle the issue of ascertainment bias that was present, obviously, with testing, COVID testing, particularly at the beginning. So that was combining, was again a sort of like an advanced statistical methods to combine the testing and the REACT randomized survey. So what we see here is that the dark green or light green means there is accordance. The light one means basically nothing is increasing over the past 3 weeks, either wastewater or prevalence, while the dark green means, things are kind of like increasing together. And you can actually see it, obviously, there is a bit of pink, which means one is going up, the other one is going down. But overall, there is quite a lot of accordance. And what we also found out was that the relationship between the wastewater and the prevalence was quite complex. So potentially non-linear and changing in space and time. Here you see all the months of the study, and here you see all the regions, and you see kind of like, they are a little bit different. Additionally, we had this, we were facing the problem that after a while, going from the pandemic to the post-pandemic era, we had less data. So randomized surveys were stopping, testing were more sparse. So we could get information on a coarse geographical resolution like regional, But then the wastewater was still there. And the wastewater, the idea was that the wastewater can track the prevalence well and is cheaper, but then obviously means that we need a monitoring system which is maintained. So what we wanted to do was to try and see if we kind of like integrate all this data together. So where we imagine we have this period where at the beginning we have everything. We have wastewater at the local level, at the LTLA level from our model. Then we have weekly prevalence at the LTLA level as well. And then we have weekly prevalence at the course level. But after a while, this LTLA weekly prevalence is not there anymore. So can we use this information and the relationship here based on these advanced statistical methods to actually predict this? And I'm not going to say much about the model, but it's sort of like just this modular framework where you have in the first period everything which is wastewater and prevalence at the course resolution and the final resolution, everything is available. And here in the second period, at the course resolution, you still have things which are available. At the final resolution, you only have the wastewater. But you see all is connected. So it's basically linking and estimating all this connection, estimating all the parameters which link all this, circles together. That was what the model was trying to do. And that was done using a hierarchical approach, accounting for spatial and temporal dependence. What we found,
2 more minutes.
Yeah. What we found was that actually the integrative framework works. The wastewater alone, which is the blue line here, is not doing so well. So in a way, actually, you need to anchor wastewater to something else. So you need to integrate it with some other prevalence or diagnostic testing data. But if you do that, actually it's doing very well. So the dots are the actual data, which we try to predict here with the model. And so you see that it's going, quite well everywhere. Now, the caveat is that the COVID-19 disease was had quite a similar trend across the nation. So it wasn't so much spatially varying. So we are now trying to do something similar with another infection and see if this framework works with another infection. In particular, we are looking at norovirus, where we have also the G1 and G2 genogroups. We have a kind of like a network which is similar. Well, it's smaller in size, but it's sort of like quite spread. So it's quite nice as well. And then we are looking at number of reports together with the norovirus concentration. This is the number of reports, and this is the norovirus concentration. And they're kind of like they're in good accordance nationwide. But then here you see that the wastewater for each region, it's kind of like there are some differences. Now, with norovirus, it's more complicated, and you need to kind of like thinking a bit more outside the box in terms of possibly getting other types of data like social media that were mentioned before. And this is something we are investigating at the moment. Now, the last thing I wanted to mention was this idea of going from sort of like this, one type of data, 2 types of data approach to a multiplex, a complete multiplex. So the idea is that we find that wastewater works well, is able to predict disease when it's linked to other data, so actually should be included in a full surveillance system. So the idea here would be to kind of like build a flexible, agile framework where you want to estimate the spatiotemporal disease process and you use all the data that are available. And this obviously is a framework that then, depending on the disease we're interested in, some data will be available, some data won't be available. But that's the beauty of this system, and that's what we're trying to do at the moment. So just a final discussion points, sort of like, I believe the wastewater is great. It's a great resource with lots of potential. It's quite easy to estimate trends of disease, less easy to estimate levels unless you calibrate it against other data. But then really, if we include that into a multiplex surveillance, I think it would sort of like really enhance a surveillance system, would be in line with the national biosurveillance strategy. On the other hand, we really need some advanced statistical methods, machine learning, AI approach to synthesize all these different data sources, accounting for all the biases and uncertainties. And this is just my final slide. All these people involved, which you appreciate are a lot, so I just wanted to acknowledge them. And then, as I promised, there is a QR if you want to access the 2 papers that we published. And the one here at the bottom is to access the wastewater atlas. And with this, I am finishing. What do I do? Here.
Thank you so much, Marta. I think it's really common for us to think about AI and bias together. It's really interesting to think about how AI techniques could be used to debias estimates and integrate multiple data sources and give us that more accurate picture of what's going on the ground. So thank you for that example. We will move to the Q&A section. So if you do have any further questions, do pop them in the Q&A chat there, and Marta and Shyam will help me in answering them. I'm going to flex chair's privilege and ask the first question, which is that we heard from Florian that the use of AI tools has a much longer history than public consciousness of the recent advances. But with generative AI like ChatGPT, there really has been a step change recently, particularly in interest and desire for AI projects. So do the recent developments represent a new horizon within your domains? And where do you think applying AI will cause the greatest change in day-to-day public health practice? I will come to Shyam first, perhaps.
Yeah, I can't start my video, but I can unmute myself. It's a really good question, and it's one I haven't got an answer to, because actually we haven't really resolved the last step. So AI to examine mammograms, it isn't really generative, and the same for other imaging technologies. It's the step before that. And there's so many things we need to sort out in terms of getting the right evidence, knowing how to put it in a workflow safely, knowing how to quality assure it, because the things that upset, so it acts different to humans. So for example, if you change the imaging technology in a way that humans can't see, it can totally mess up the AI because it's doing something we don't understand. And so we haven't done the step before, and we're focusing on the step before, and I have no idea. And we need to start thinking about it. I haven't seen many suggestions on how it might be used, certainly in very complex ways. You know, there's very simple ways in terms of helping to write up reports and that sort of thing, but actually they're not as controversial, are they, as long as it's being checked by a clinician. So that was a long version of I don't know.
Thank you, Shyam. Very helpful. Marta.
Well, you know, I like the I don't know because I don't know either. I can say that in terms of generative AI and in my field as a statistician, I could see it quite usefully used for checking codes, for instance, or helping writing codes, or even though, again, with caveats, because just by, you know, it's sort of like personal experience, sometimes you sort of trying to ask for help on codes and the codes are not necessarily, you know, running as they should. So it's kind of like, in a way, I'm finding it, whatever we are using for, it's always super important to kind of have, you know, not kind of like use it as, you know, the truth. It's really always, in a way, it needs to be rechecked and rechecked. So it can help, but with lots of caveats, and still, I think, which, you know, it's, yeah, I think that's, yeah.
Still needs to be a human in the room. Lots of people will be relieved to hear that. Got a question from Jack around commission decisions being made to purchase AI screening and diagnostic tools without public health advice in the room. Vendors will often point to medical device approval as evidence of safety and effectiveness. What can public health professionals do to get into that space to remind everyone of screening basics, Wilson and Younger basics, and to influence those decisions?
I think this is to me, isn't it? I think this is really critical. And it's really difficult. And it's difficult because of those Oh, there we go. There we go. I'm here. It's really difficult because of those different perspectives. And I think outside of the public health community, there is not broad understanding of screening and screening principles. And that includes the general public, that includes the press, and that includes, you know, a lot of government. And why would they? Because it's quite a niche area. And common sense doesn't really apply to screening. You know, when you apply common sense, it doesn't really pan out. And so actually, there's a wider piece to do about communication, about screening, and we're making inroads on that. But we've got to go a lot faster because there's a lot of interest in screening and a lot of misunderstanding. There is also a need, I think there's a need for direct outreach, to have the conversations with people who've developed the test, who will want to and assume that their test is going to improve health outcomes. But they will assume that by getting a true positive, their test will improve health outcomes. And I think it's those one-to-one conversations where you explain for the exact context what you need to deliver better health outcomes. That's how we'll sort of get through. And it's sort of one case by case, one by one, I'm afraid.
I'm hearing much more integration and collaboration between different sectors, and perhaps with people developing the tools. That brings me to pose your question back to yourself, Sian, and then I'll come to Martha with the same question, which was, how can academic and industrial communities to come together to reach common understanding?
It's really hard because I don't think there's enough public health people. And so all of the public health people end up being quite stretched already. And so it's hard to find time to do that communication. So part of the answer is building the workforce and the training of people who understand screening. And we do some of that at Warwick. We hold a master's module. We're going to expand that and develop a one-day course for industry and produce sort of communications materials. And some of the work I'm doing with the National Screening Committee is trying to produce a set of position statements that are helpful, that sort of explain the principles in different contexts, that people can use as a sort of, you know, not having to explain everything from scratch every single time, but can just say, oh, there's a position statement, have a read of that. And that's a starter for the conversation. And we found that really helpful. And we're trying hard to do lots of that. That's not a complete answer, though. And I'm really interested if people have other bits of the answer.
Excellent, thank you. That's perhaps something that the FPH-SIG could be involved with, helping to develop and really setting that clear stance from a public health perspective. Martha, I'll come to you with the same question, which is about bringing industrial and academic communities together.
Yes, which is, I would echo Sian saying that is really hard. In a way, I feel sometimes what is needed, obviously, you know, what Sian was saying about building the workforce is super important. And also maybe kind of during the training, you know, sort of like at the master level, trying to enhance opportunity for collaboration, for kind of like for the student to see what is out there and what, you know, it's kind of like really start with the education in a way. But I'm also wondering if there should be some sort of attempt from a top to the bottom kind of like approach, you know, from, I don't know, UKHSA, the government, someone kind of like could try and put together some focus groups, some kind of like expert groups, which really force people to, you know, to stay together, to do something together. Because, you know, let's face it, academics can be a bit of lonely, sort of like hard, you know. We like doing what we do, and sometimes it's kind of like hard to make the first move and approach, you know, someone from the dark side of the industry, for instance. So something like that, I think, would be really helpful, potentially.
Amazing, thank you. And we've got 140, and it was up to 160 participants on the call area. So hopefully this is part of that building expertise, and I'm sure the faculty would love to play a convening function. We would love to play that convening function of bringing people in the room together. I've noticed the time, so I'm going to close our Q&A section here. I know there are questions in the chat around ethics and equity, and I'm saving those for the second Q&A, which we'll do at the end of the next session. Once again, we'd just like to thank Marta and Sian for sharing their wisdom and experience in applying AI. We can't actually hear or see the audience, but we'll have to imagine the emphatic applause that I'm sure both of them will be getting. If you have been inspired so far, then during the break, please do think about joining one of the special interest groups. If you're an FPH member, you can join the Faculty of Public Health, AI and Digital Public Health STIG. If you're not an FPH member, then you can join the sister group at the Turing, which is the AI and Public Health Supergroup. I'll pop the links in the chat. I'm going to move to a 5-minute comfort break now, so please do stretch your legs and make a cup of tea. And then if you come back in 5 minutes, just after 5 minutes past, for the next part, we will be looking at the ethical and equity challenges of AI.
Hello, everyone. I hope you enjoyed your break. I think we'll get started to make sure we can finish on time. My name's Samantha Field. I'm one of the other co-chairs of the Faculty of Public Health, AI and Digital Health Special Interest Group. And in order to give our last session on ethics and AI, I don't think there's anyone better to present this topic than Christopher Burr, who's a senior researcher at the Turing Institute, and he's the head of the Innovation and Impact Hub. Chris specializes in the trustworthy and ethical design, development, and deployment of data-driven technologies, and he's leading the Trustworthy and Ethical Assurance of Digital Healthcare project, which aims to harmonize existing research and work in trustworthy and ethical assurance. We'll definitely get you off on time, but we should have some time at the end for our Q&A with Chris and any of the other panelists who are still on the call about ethics and AI. So do put any questions in the chat, and I'm going to hand over to Chris now for his presentation.
Thank you very much, Samantha, for the kind introduction. Let me just share my screen and go full screen, and hopefully someone can just quickly let me know if that's displaying okay.
All good, Chris.
Fantastic. Thank you very much. It's always nice to be introduced and not have to worry about doing it on the first slide yourself. So I can jump straight in actually with a little story. So I think it's always nice, especially after a little break, just to ease everybody back in. So imagine the following situation. There are 3 children and they're arguing over who has the rightful claim to a flute. Anne claims that the flute belongs to her on the grounds that she is the only one who can actually play the flute and would therefore gain the most enjoyment from possessing it. Bob claims the flute should belong to him on the grounds that he is the only one among the 3 children who is unable to actually afford to buy any other toys himself. And then we have Carla, who claims that the flute should belong to her on the grounds that she was the one who actually made the flute in the first place. None of the children deny the claims of the other 2, so we, for the purpose of this, accept all of these as true and valid claims. The question, which I'm not going to ask anybody to raise their hands because no one can, but just momentarily think how you'd answer the question of, is it fair to give the flute to Anne, Bob, or Carla? So the story comes from the Nobel Prize winning economist and philosopher Amartya Sen in his seminal work on the idea of justice. And it's designed as a way to sort of test our intuitions about how we should weigh up and evaluate potentially competing claims about fairness on the basis of their respective merits. In this particular version of the story, the children are there to represent competing theories, moral and economic theories of fairness that emphasize different values. So for Anne, she's taken to represent what we'd call the utilitarian theories of fairness that prioritize maximizing the overall welfare of the group, which in this instance is basically the most happiness that is generated by Anne having possession of the flute because she can play it. Bob is taken to represent economic egalitarian theories of fairness, which emphasize equal or equitable distribution of goods. And then we have Carla, who represents so-called libertarian theories of fairness that prioritize things like freedom or autonomy to pursue one's own interests or to make your own decisions. And all of these theories have applications both in clinical uses of healthcare technology and, of course, in public health as well. And I'm sure many of you can probably think about how those values apply to the context of the flu would also apply in the context of distribution or allocation of healthcare resources. Now, the purpose of this little story is just to kind of highlight, well, a couple of things. For Sen, it's to highlight where these values can come into tension. And obviously, not all toy models are quite as simple as this one, but nevertheless, values that are related to fairness do in fact come into tension. And this is a nice illustration of where that is the case. There's no easy solution to this problem. It requires that kind of discussion, that deliberation about the evaluation of different reasons and merits that are provided. And I imagine if we did have an option of trying to ask where people decide, where people fell in that question of who, which of the children it's fair to give the flute to, there would probably be some disagreement. But it also serves another purpose about highlighting the need to make the actual claims very transparent and accessible and make them out in the open as a way for us to be able to actually evaluate and assess them. Because when we are dealing with something like fairness and with equity, we are going to naturally have many different values, some of which will come into conflict. And therefore, it's important that we are able to transparently make claims very accessible, very transparent, very sort of open, so that people can evaluate and hopefully critique them. And this is where the trustworthy and ethical assurance work comes in. Now, as mentioned at the start, that this is related to a project on trustworthy and ethical assurance of digital health and healthcare. Although I did lead that project, that actually ended at the end of last year. We've got a policy report that will be coming out hopefully in the next month or so. But there is a sort of a follow-on to this project, and it's the trustworthy and ethical assurance of digital twins. As was mentioned, I lead our innovation and impact hub for the digital twins cluster at the Turing. And this is a new project that started in February, funded by the UK's Research and Innovation Agency and the BRAID program, basically applying this to carry out scoping research and continue the co-creation of the tools and practices, which I'll talk about shortly, but in the context of digital twins, of which health is a specific key priority area for us. I will also just flag that most of the use cases that we have currently focused on, and if I have time, will showcase are more clinical applications of AI technology or digital twins rather than the public health setting. But I believe what I'll be talking about will generalize to public health as well. So I'd like to quickly walk through the following three sort of sections. First one, I'm just going to talk about what I mean by trustworthy and ethical assurance and hopefully give you an indication of where it could be useful. I'll then speak a bit about fairness and health equity. And as I said, if I have time, I'll provide a little demo case using the actual platform for people to see how we've worked on it so far. So starting with the most general kind of definition of assurance, when I talk about assurance, I talk about a process of building and communicating trust. So for instance, when I was invited to give the talk today, I gave some assurance that I would be here on time and that I would have my slides ready to the organizers, and I sort of made that kind of claim and I made that reason. Whether or not there was any evidence required for that I was actually going to follow through on my claim is another matter, but nevertheless, I was providing assurance that I would indeed turn up. If I was particularly unreliable, then maybe some evidence would have been required that I would in fact actually be here on time. But things like this are very commonplace in everyday sort of communication. When we give our assurance, either we make specific claims, maybe implicit claims, and depending on how trustworthy they are, sometimes people will ask us for evidence to back those claims up. Trustworthy and ethical assurance is very similar to this sort of everyday notion of assurance, but we can define it in the following ways. Trustworthy and ethical assurance is a process of using structured argumentation to clearly demonstrate how a set of claims about some goal of a system are warranted given the available evidence. I have a background in philosophy, so I love definitions, but I appreciate sometimes they can be a little bit confusing without unpacking them. So let me focus on the following 4 points. The idea of it being a structured form of argumentation, and then these 3 properties. And the best way to unpack that is to give you an example. So in front of you here, you can see another sort of toy model, like the children and the flute toy example. Here's a toy model of what we would call an assurance case, a graphical representation of that structured argumentation. And it shows the 3 elements of goals, claims, and evidence. So at the top, we have a claim about an AI system. Doesn't matter which AI system is that we're discussing at the moment. It could be for any domain, not just public health. But let's say we really want to emphasize and provide assurance that this particular AI system is explainable. Obviously, a very key property in the context of public health, where people want to be able to understand the rationale behind decisions and maybe use that to sort of ensure there's informed consent in participation or collection of data. So that's the goal that is being aimed for. And the way that we communicate the assurance or justify that that claim has been made is by setting out a set of claims about the project and the system that we're referencing. That may be, for instance, that the trained professionals operating the system actually know how it operates and can extract an explanation for that. It may be that the model that is used is intrinsically interpretable. It's not a form of deep learning that requires some sort of additional method to try and extract some interpretation. And it may be that the features used by the model are meaningful, that there has been some sort of clinical validation or validation with experts to ensure that the features being used to train a model actually make sense within the particular problem domain. And then underneath it, we have these forms of evidence. So for instance, if we want to claim that the features used by the model are meaningful, maybe we need a description to actually back up, and it's not just a claim that people are taking at face value. Now, this is a simple example, but assurance cases such as these are well used. They've got a long history in safety critical domains like aviation and energy. This little animation that's playing here at the moment, it's an example of a very long and more complicated assurance case, just to highlight the fact that they're not all toy models. And this is for an autonomous vehicle from Uber, or it was rebranded as Aurora. But you can just see, you don't need to worry about the text. It's just showing that they also get a lot more complicated than the toy model I presented. And our collaborators for this particular project at the University of York have been working in this field for decades. And although there is this long history in safety critical areas like aviation, sort of expanding that beyond that traditional domain is something that has only happened recently. In fact, in the last decade, there has been quite a bit of work with the likes of the Health Foundation and others to try and see whether or not this particular methodology extends into healthcare. What we're doing is not just thinking about it in the context of safety or clinical efficacy, but also trying to think about how you could actually communicate reasons to justify ethical properties. Which then actually leads you on to the question of, well, which principles should we try and assure? If we're thinking about assuring ethical principles, which ones? We have our own framework at the Turing. We call it the safety principles. Stands for the following set of principles that you can see here. So sustainability, accountability, fairness, explainability, and data stewardship. And many of the examples we saw from the previous speakers gave good examples, for instance, of where these principles are being considered and how they're being operationalized. I'll talk a little bit about the notion of fairness, but I also just want to flag that outside of health as well, there is work being done within the regulatory space, such as from this report from the Office for AI, now rebranded as the AI Policy Directorate, that set out principles for general AI regulation, which in addition to fairness, also emphasizes fairness as a key principle that requires assurance. So some people take this kind of principles-based approach. Others also try and set out more kind of domain general, non-principles-based approaches, like the recent EU's AI Act, as well as the risk management framework set out by the National Institute for Science and Technology over in the United States. I think all of these different approaches are useful. Although I have some kind of more critical perspectives on the risk-based approach in the sense that it often focuses too narrowly on trying to minimize harm without necessarily evaluating the public benefit that comes from these AI systems, I think there is a sort of need to try and sort of let 1,000 flowers bloom and let all these kind of approaches sort of demonstrate the value that they have in the different domains. But there is a downside, which is that it becomes quickly overwhelming to try and understand which of the principles, the standards, the best practices actually have any value. So we're taking a slightly different approach. Although we have principles at the Turing, the Trustworthy Ethical Assurance platform is actually framework agnostic. And what we're trying to do over the next couple of months is actually take a much more open and community-based bottom-up approach. So what we'll be doing is in the context of health digital twins, as well as natural environment and infrastructure, we're going to be working with key developers who are building digital twins. But again, this I hope will be of interest to those of you in the public health space, given that there is relevance to it. To start building out a structured repository for sharing assurance cases within the communities as sort of a form of knowledge share. And the idea here is that we are trying to sort of see which tools, which techniques, processes, standards, best practices people are actually using, and how specifically they serve as forms of evidence to justify specific claims. Maybe, for instance, like fairness. So, do people, for instance, always use some statistical measure of fairness, or are there particular tools they use for thinking about which sort of fairness statement and claim would be relevant within a particular project? Do they use tools like the Fairness Compass, which is a very good tool developed by the French insurance company AXA, for thinking through which types or definitions of fairness are relevant considering the particular problem that you're trying to address? By building out this repository of assurance cases, we enable people to do this sort of structured form of knowledge share using this kind of common platform that we've built. We also have created new features in this platform to allow for collaborative editing and dialogue, so for the community to speak with each other, maybe to contest whether or not a particular form of evidence or standard from ISO or BSI is actually relevant to justify a particular claim. But the hope is also that this enables a much more structured form of querying the actual assurance cases to see which patterns we can then generalize from. And the idea here is the more we can create these generalizable patterns, the more people then have templates that they can start from. So we envision a situation where people can load in a template for instance, fairness and health equity that says, here are the sorts of claims and types of evidence you're probably going to want to consider from the very earliest stages of your project's lifecycle, to hark back to Florian's talk at the beginning when he set out that lifecycle approach. We're also working directly with the Department of Science, Innovation and Technology, who have recently written a report on Introduction to AI Assurance, again, domain general. But what's nice about this report is it sets out the actual bounds of an assurance ecosystem, explaining where the different actors like researchers like myself or auditors or lawyers all play a role within this particular ecosystem. As I said, they're our key partner in both the previous project that was mentioned at the start, as well as this new one. And the one concept I want to draw out of this report, they again don't necessarily set out a sort of a principles or framework, so it's not adding to that kind of overwhelm I mentioned earlier, is this notion of justified trust. And I think this is an important concept because a lot of people focus on trustworthiness, we do as well, but sometimes to the neglect of this idea of trust that is also required. So for instance, I could communicate to you all the trustworthiness of my system, but it doesn't necessarily guarantee the social license or trust that would actually allow that system to be deployed. A very big issue in the context of public health, as we saw, for instance, during the COVID-19 pandemic. Similarly, people can trust things that really they shouldn't. There can be untrustworthy systems as well. People can irrationally place trust in a system that they really ought not to. So the crux here is that we want both trust and trustworthiness to ensure that we have a justified form of trust. And this is where assurance can contribute. As I said, we have been working with them. We're an example of the research bodies in that report that they highlight. We're going to continue working with them to make sure that we align to the sort of regulatory ecosystem that they're detailing. Now, I don't think I have time actually now. I'm sorry, I never know how long I'm going to talk for to actually go through the demo, which I was hoping to do, and showing off a fairness and health equity assurance case for a digital twin of a human heart. This is with some collaborators at Imperial College London who are developing a digital twin to allow clinicians to take MRI scans, feed it through a machine learning pipeline, and develop a 3D visualization of a human heart that can support clinical decision-making and patient and participatory decision-making with patients. Again, I know it's not a public health example, but it's the one we have some specifics for. So maybe what I can do, given I've run out of time, is instead just pop a link into the chat from a flyer we had at AI UK recently, which will allow people to follow up with the relevant links. But I'll end instead with just saying, if you are interested, we've got a big series of engagement activities over the next couple of weeks. QR code there will take you, I believe, either to our documentation site or our GitHub repository, where our platform is available for download, for use. It's all open source. You're welcome to play around with it, but you also can reach out if you have any questions. And because we're looking at building out more and more case studies at the moment, if specifically you have a project where you're interested in looking at how you would assure for notions of fairness and health equity, please do get in touch. I'd be very happy to speak with you. But I'll stop there because I think I'm at time.
Thanks so much, Chris. We probably have time for one question, and I think I'm going to choose the one which is probably at the forefront of a lot of public health minds. And that's about how we build in mechanisms to ensure that AI tools don't drive or exacerbate inequalities or disparities experienced by communities and minority groups. So I don't know if you have any ideas of that, or any of our other panelists can jump in.
I can say something very, very quickly, which I think I maybe mentioned at some point. The whole tool has been designed to specifically not be a piece of compliance where you just tick things off at the end, which we've seen in the past, and we've specifically designed this tool not to be. Instead, we've actually specifically made this to be something that can aid reflection, deliberation as a project lifecycle sort of proceeds. Our pattern, our template for fairness specifically emphasizes stakeholder engagement. And therefore, one of the best ways to address that is simply to carry out structured forms of stakeholder engagement. And we have in addition to the template, we have a guidebook that, again, is not specific to public health, but I'm confident that a lot of the activities in that structured assessment would be relevant, because we have tools for sort of bias self-assessment that help people think about those questions, and it then feeds into the development of an assurance case. So I'd say if I was highlighting one, it would be diverse and inclusive forms of stakeholder engagement, where you can sort of document that those kind of conversations have been considered, and the possible trade-offs between different values or notions has been actively considered. Even if you don't get to solve it, sometimes formation of consensus is really what you're aiming for, even if you can't get the perfect solution. And the only way to do that is through stakeholder engagement, or PPIE, I guess, in the context of public health.
Yeah, do you want to jump in?
Yeah, there was a sort of question about the breast screening example in relation to this, and it is a bit worrying. So we know that the natural history of breast cancer does vary by ethnicity, and certainly women with Black ethnicity tend to have more aggressive types. And there is some evidence that the existing test works less well for them. And we also know that the main driver of uptake in screening is socioeconomic status. So the people we have coming are the economically better off. And so what are we training the AI in? We're training the AI in people that are coming now. And there is some AI systems that actually have been training AI, primarily in a Caucasian population. And that's worrying, because AI is a black box. And then we don't know, well, what's the accuracy? And so what we're planning to do is just do a very large test set study of different ethnic groups, take the different AI vendors, apply them to all the different ethnic groups, and just compare and see. And so we're thinking we're not going to sort of go through the whole process of working out how the AI was developed or what it's doing, but actually just look at the final product and see how the different products compare.
You make it sound so simple, but I'm sure it's a lot more complicated than that. Well, I'm going to say thank you to Chris and our speakers, and hand back over to Alisha so we can try and wrap up on time.
Thanks, Sam. Oh, stay there, Sam. I was going to yeah, just well, on behalf of Sam and Elliott and myself, it's just been fantastic to have you all with us for a couple of hours, and as a bit of a whistle-stop tour, we know that across lots of different areas of AI and digital health as well too. So we really look forward to you as members, either, as Elliott said, through the Faculty of Public Health special interest group with a focus on AI and digital health, or if you're not a member of the faculty, we put a link in there to the group, the kind of sister group that sits under the Turing, and people are more than welcome to join both as well too. And the Turing will have is open to everyone, irrespective of whether or not you're a member of the faculty. This has been the first, so there'll be much more to come. Give Elliott, Sam and I a little while, and then we're going to reach out to you all. We've got a survey that I'm hoping Heather's going to pop in. There we go. A quick feedback loop. It'd be wonderful to get your feedback. What did you enjoy and what would you like to know more of? And just lastly, we'll be, as I said, we've recorded it, so we'll pop that up, so you can listen back to that as well too. So yes, just a fantastic, huge thank you to all our speakers, and we hope to see you all again soon. Thank you.